Hello, everyone, and thank you for joining us today. We will get started at 1 o'clock p.m. Eastern Time, so please set up your audio and web video, and the webinar will begin shortly. All right, it is 1 o'clock, so we will go ahead and get started. So welcome, everyone, and thank you all for joining us for a webinar from the National Association of EMS Educators in collaboration with the National Registry of EMTs. If you're a returning listener, welcome back, and if you're brand new to the NAEMSE webinar series, we're very glad that you joined us today. Before we get started, I'll fill you in on some of the controls available to you today. Attendees are in mute-only mode, but please submit your questions by typing them in the Q&A panel on your Zoom screen. Questions will be held until the end of the presentation. Today's webinar is being recorded and will be available on our YouTube channel and our website following the presentation's conclusion. NAEMSE offers 1 hour of CAPSE-approved CE credit for those who attend today's live webinar. There are a few steps to receive the CE certificate. First, I will send a link in the chat at the end of the presentation and include it in tomorrow's follow-up email. You must follow this link and register for your CE certificate on the NAEMSE website. NAEMSE members receive the certificate free of charge, and it is $25 for non-members. We are proud to announce that today's webinar is in partnership with the National Registry of EMTs, entitled Content Validity in Action, Exploring the National Registry Examination, presented by Dr. Paul Rosenberger. I'm going to pass it over now to Paul. Paul, thank you so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thanks, Rio. Hi, everyone. My name is Emily Kirchner. I am the event coordinator here at the National Registry. I just wanted to go over a few pieces of housekeeping before we get into things. Today's webinar will run for a maximum of 1 hour. And as Rio said, please submit your questions via the Q&A function. Any questions in the chat we can't address. We just have a lot of people online today, and we want to be able to get to everyone's questions as efficiently as possible. And with that, I will hand things over to Paul.
All right. Thank you, Emily. Thank you, Rio. Good morning and good afternoon, depending on where you are in the United States. But anyway, so today we're going to continue on with some of the content that was delivered back in December of last year. And to kind of point out what we're going to discuss today is really start off with what is the role of National Registry, talk about this framework, which we call the Examinations Development Lifecycle, and what does it mean for constructing valid and reliable examinations. I then want to move on and talk about some specific developments in our examinations, particularly the ALS Psychomotor examination discontinuance. And then in the session, talking about the most recent 2023 BLS Practice Analysis. So those are really the 4 to 5 things that we'll cover today over the next 60 minutes. All right, so let's first talk about the role of National Registry. And so when you think about what it is that National Registry does, our primary role is that of a certifying agency. And what that really means is that we take a third-party outside view and assess the competency of the candidate who takes our examinations. But beyond that, with you, we're a partner in that process that ensures the health, safety, and welfare of the public. So when we get a citizen who comes to our classrooms or goes through that entire process, together, we help ensure that that person is competent. And so in the classroom, you teach them and assess them. And if they meet all the requirements of your course, you then pass them through the course and say that they're eligible to take the National Registry examination. At that point, they come to us in step 2, and then we take a snapshot of their knowledge, skills, and abilities to determine if they're competent or not. If they are successful there, then they go on to the state, they license, and the licensing is done by the state, and they go in and assess, is the person eligible to operate in that particular state. And then finally, when they're employed, they are credentialed by the organization and the medical director of the organization. But in a nutshell, it takes all of us. It takes the educators, it takes National Registry, it takes the states, and it takes the organizations who employ our providers to make sure that they're fully competent. And it is truly a systems approach to ensure that competency. Number 2, when a citizen calls 911, they expect that a competent individual will show up at their doorstep. And so we help satisfy that public demand for standard and to ensure competency. Through step 1 and 2 up there, we're able to elevate the stature and the credibility of our profession. And we're also able to help in conjunction with the stakeholders that we work with to ensure the quality of services that are offered by our certified individuals. For the employers, we're able to help identify candidates who are qualified to actually go out and perform the duties of EMS. And then when you think about it being a national certification, people are able to take that certification from one state to the next. So if a person goes to school in Texas and they gain National Registry, they're able to use that registry license to move to Illinois or North Carolina or California or anything in between. So that's the role. That's what we do at National Registry. I want to move on and then talk about part 2, which is this concept of test development. And so the part 2 here is talking about the examinations development life cycle. And I'll show you the framework for this in just a second, but really what the life cycle is a framework that's designed to help us build our examinations so that they actually measure the intended knowledge, skills, and abilities that are required for our providers, which are EMRs, EMTs, AMTs, or paramedics. It also helps us ensure that our examinations are valid, reliable, and legally defensible. And it also helps us ensure that our tests are fair, clinically accurate. So here is the life cycle, and this is going to be the biggest part of the presentation today, but we'll talk about the life cycle in its totality here, and then we'll go in and we'll talk specifically about the 7 steps that you see here. So we start at the top. We start at 12 o'clock, and the first thing that we do is conduct a practice analysis, and the name actually is exactly what we do. It is a study of the practice of EMS. And so when we have this done, we know what it is that EMS providers do on a day-to-day basis when they actually go out and work day in and day out. And I'll talk more about this in just a second. Step 2, when we have a practice analysis done, we know what it is that these providers do. We then create test specifications. And what that would look like in the classroom is a blueprint of our examinations. That's step 2. Step 3 is a really big, huge step. I would show that if I was creating this life cycle here, I would show that as 2 steps. But there is at this step where we write the examination items, and then there's a major review process to make sure those items are clinically up to date, accurate, they're fair, all of those things I mentioned just a minute ago. When they move from that phase, they then move out to the tests, and they are piloted. And that simply means that they are introduced to candidates who take our examination, but they're not scored. And when it goes into this phase, we're just capturing data on the items just to determine how they performed or didn't perform. After the pilot phase, then they go into a statistical analysis, and our psychometricians look at these items and actually see how well they did perform or didn't perform, and how easy and how hard these items were. If they don't meet the muster, then of course they go back into a rework phase. But if they do meet all our requirements, then they move on and become operational. After that, they go to a standard setting session. And this is really where we look at the cut scores on our examinations and determine, what is a minimally competent EMS provider? What is it that they have to know to go out there and practice safely day to day? And then the final step there is this ongoing evaluation, where every time we take examination items off of the active test, we look at them and evaluate them and make sure that they're meeting the metrics that they're supposed to meet. If they don't, then they get removed from the test and new items are inserted into the test. But that's an ongoing evaluation, and that actually is done daily. We're always looking at the performance of our items every single day. So that's the life cycle. Those are 7 steps. I'm going to go into each of those steps in a lot more detail here, but that's kind of the big picture. That's the roadmap of where we're going. So, okay, back to this first step. As I mentioned a minute ago, the practice analysis is that it's an analysis of the practice of EMS. What we want to know when we conduct a practice analysis is what it is that EMS providers are doing. And this is the foundation for our content validity. And all that really means is that our test represents all of the aspects of a given construct. In this case, we're talking about the construct of EMS. And so we're measuring things like, can a candidate manage an airway? Can they manage respirations and ventilations? Can they take care of a cardiac patient? Can they take care of a trauma patient? Can they take care of a patient who has a medical emergency, an obstetrical or a gynecological emergency? And do they know what they need to know about operations? And so we also want to know here, what's the populations of patients that they're seeing? Are they seeing, how many adult patients are they seeing, pediatric and geriatric patients? These are all things that help us construct our examinations. So let's talk about the most recent ALS practice analysis. And the most recent practice analysis was conducted in 2019. And this, when I talk about ALS, I'm talking about providers who are AMT level or paramedic level. And so in 2019, the practice analysis was released from the study that was conducted over 2017 and 2018. And this practice analysis was actually conducted in 3 phases. And so we first went to the NAEMSE data set, and the data set really gave us a really good idea of what the types of calls that EMS was running and the frequency of those calls. And so when you look at this data set, you'll see that it gave us information from 10,000 agencies who operated in 49 states or territories. And it also gave us a global perspective of over 29 million EMS incidents. And so phase 1 really just gave us the information to say, hey, what is it that EMS is running? What type of emergencies? And what's the frequency of those emergencies? But that didn't tell us enough. We needed to know more. So in phase 2, we moved on and we worked with 4,000 participants who helped us identify, okay, that's great. We know what people are doing, what they're responding to and how often, but it really doesn't tell us about the incidents that have high potential for harm if we don't do things correctly, or those incidents that have high criticality. And so the best illustration I can give you here is, I think nobody would be surprised if I told you the #1 adult emergency in America was traumatic related. And we'll for sure put that on our examinations. But one of the emergencies that didn't show up with great frequency is like a pediatric cardiac arrest. And yet, as you know, that's highly important that we know how to manage those incidents because there's high potential for harm and those patients have high criticality. And so phase 2 helped us identify, the potential for harm and the criticality so that we could weight the examination so that we were capturing type and frequency, potential for harm and criticality. With phase 1 and phase 2, then we moved on to phase 3. And in phase 3, the National Registry brought numerous subject matter experts in several different panels to talk about these types of calls, calls with high harm potential and criticality. And we wanted to identify, what are the tasks associated with responding to those calls And when we had those tasks identified, we wanted to know what are the skills, the knowledge, and the abilities that a candidate had to know to actually practice in a competent manner. That phase 3 was actually led by industrial and occupational psychologists from the University of Akron. And they helped us identify those tasks and those KSAs that we would eventually want to test for our examinations. The 2019 practice analysis was done in a super duper manner. And it actually informed the folks who wrote the education standards and the folks who wrote the most recent scope of practice model. So it was a very big project. It actually took several years to conduct, but the 3 phases helped us get a good understanding of what it is that EMS does. Give you a few little bit, going off the path a little bit here, but when you look at what are the top 5 emergencies for adult and pediatric, they're listed on this slide. What's remarkable to me about this is they're almost the same 5. The only thing that really trades out is the syncope and fainting is number 5 for the adult, and the seizure is number 4 for a pediatric encounter. And so when you think about it, these are almost the same top 5 emergencies that we're seeing. And this is, a finding from the 2019 practice analysis. Why am I covering this? The reason being is, as educators, you should know that these are emergencies that you will absolutely see on our examinations, because our 2019 National EMS Practice Analysis indicated these are some of the most common emergencies that a EMS provider will run when they leave the classroom and start taking care of patients in the 911 setting. Another thing I don't have on the slide here, but when you look at the proportion of calls, 94% of them are adult and about 6% of them are pediatric, and our tests are weighted in a very similar fashion because of that. The 2019 practice analysis also created the need for us to test this concept of clinical judgment. And so when you look at this list, the airway, respiration, ventilation, cardiology, resuscitation, trauma, med OB-GYN, and EMS operations have been on our test for a super long time, for as long as I can remember. But the 2019 practice analysis also told us that we needed to test this new domain called clinical judgment. And so I don't have time to cover clinical judgment today. That's probably a 2-hour session alone. But it is a new domain, and that domain will be tested starting July 1, 2024. And the clinical judgment domain also includes aspects of leadership and communication. The BLS side has been looked at too, most recently in last year, 2023. And we'll be promoting a whole lot more information about this very soon, but I'll start to cover it today. But the BLS practice analysis, and so here we're talking about EMR and EMT providers. This particular practice analysis was conducted in 4 phases, and so it was done slightly different. It was done with a different group of psychometricians and SMEs, but the results were very similar. And so phase 1 was a observational study where staff went out and rode with various EMS providers. The goal here was to identify those tasks and generate the knowledge, the skills, and abilities that are needed for a clinician to go out and practice at the EMR and EMT level. In phase 2, they then interviewed those providers and said, okay, are we capturing those tasks and those KSAs that an EMR and EMT would need to know to practice safely and competently when they actually become a 911 provider or a provider in this setting. Phase 3, SMEs were brought to Columbus, who included educators, EMRs, and EMTs, and they were all asked, hey, look at this task list, look at these KSAs that have been identified, and let's make sure that they're accurate. And so one thing I will tell you is this SME group included people who were outside and inside of the 911 system. So it did include EMRs and EMTs that practiced in industry, folks who were in the park service, people who practiced in the hospital and the jail, as well as 911. So it actually had a pretty broad perspective as to what it is that an EMR and EMT does. In phase 4, with all of that captured and validated through observation, interviews, and a SME panel, it then went to a survey. And the survey went out to about 800 participants, and they helped us validate those tasks that are performed by an EMT and an EMR when they actually go out and practice. So here is the new content areas that will probably begin somewhere in 2025. But they did identify the domains as being scene size up and safety, primary assessment, secondary assessment, patient transport and treatment, and then operations. So these are the domains, and this will be the new look for the BLS examinations in the near future. So there you go. That's the practice analysis. The practice analysis is just that. It studies the practice. It informs us as to what it is the practice of EMS is. And so the 2 most recent practice analyses were conducted at the ALS level, which included AMT providers and paramedic providers. And then last year, we conducted a BLS practice analysis, which captured those tasks, those KSAs of the EMRs and the EMTs. So with that known, we know what folks do. Step 2 is to take the findings and help us develop content domains or specifications for our examinations. And so, again, we know the frequency, the types of calls, we know harm, we know criticality, we just know what's going on in the EMS field. And from that, we then are able to create test specifications. And so from the practice analysis, we say, okay, this is how the test should be constructed because this is what folks are doing. To an educator, that is a blueprint, because I know that you blueprint your examinations and you say, I want so many items in this area, so many items in this area, but it's just test specifications that are similarly blueprints. At the third step here is actually now we have specifications. We know the content that we need to be writing. And so we begin the writing process. And so this is really probably 2 different steps. The items are written based on those specifications. And then they're later reviewed by subject matter experts. And those experts help us to determine the accuracy of those items, the fairness, and the competency and all that related to those items. The items ultimately, before they go to the pilot, are reviewed, and they're reviewed for clinical accuracy. Every single item at Registry has a reference and a rationale behind what is the correct answer and what is the incorrect answer. These items go through an internal review where we look at them to make sure that they meet our style and our branding. And also, it also goes through an editorial review where we have an editor to look at these items and make sure that they're grammatically correct and it meets our style guide. When we write items, these are our goals. We want the items to examine higher order thinking. And we want the items to not have a barrier to a candidate who actually is competent or knows the material. But we do want to have barriers to candidates who are not competent. And so if they don't know the content, then of course we wouldn't want them to be able to answer the item correctly. We also try to reduce construct irrelevant variance. And all that simply means is that we don't want these to be reading assignments. So we wouldn't have an item that says on a dark, starry night at 2 o'clock in the morning, the birds were chirping and the wind was howling and everybody was happy. And then all of a sudden there was a gunshot victim who bled profusely. When you look at our items, the lead-ins tend to be about a sentence or 2. And so we're just asking them, okay, with this information that's provided, do you know what to do with this particular situation? We also try and avoid construct underrepresentation. And that just simply means content's not reflective of the relevant knowledge. I can give you an example of that. When I was in paramedic school, I was asked to calculate oxygen flow rates and how long an oxygen cylinder will last. at a certain given flow rate with different PSI readings and all of that. To me, that's trivial content, and that's not content that would be found on a national registry examination. We really want to know, can you take care of a patient, and not necessarily be able to calculate the length of an oxygen bottle. Often we're asked where the questions come from. The truth of it is the questions are written by SMEs in the field. These are working paramedics, AMTs, and EMTs who write items on behalf of our industry. The truth is there isn't a group of writers at National Registry who write these items. We just kind of facilitate the process. And so these items are written, again, by lots of people across the nation. We have folks who are writing items from every region in the nation. The folks have diverse backgrounds and a pretty broad range of experience. And these people who write these items are trained by us so that they know how to write a high quality item for the examination. After they're written and they go through the cleanup process and through the grammar review, they are taken to a panel. And those panels include about 5 to about 10 individuals who look at those items, and they're asked to help us refine those items and make sure that they're fair, accurate, and everything that we want it to be. And if they don't meet the panel's approval, they go back into a trash heap, basically, and they're rewritten or they're discarded. But if the panel likes them or we can refine them to their liking, then they're moved forward to that pilot phase. But again, this is done by experts in the field. Here is a recruitment pitch to you that if you want to be part of this process, we would love to have you. I will say that each panel only has about 5 to 10 individuals, and we do about 1 panel a month. So there's not a lot of opportunity to do this. But if you're interested, please reach out. There are definitely regions in this country where we have high needs for help. In the South, we just have a ton of people offering to help us with this. But there are other regions in the nation that just doesn't really aren't as quite as volunteering. And so again, if you want to be part of a panel, we would love for you to reach out to us and let us know of your interest. Okay, so now the items have been written. The items have been reviewed, both internally and externally. We've gotten the thumbs up from that SME panel to say, hey, this item looks really good. Let's put it out there and see how it pilots. And so then we move on to that pilot phase. So at this point, the examination items are placed on a test and they're piloted. And that just simply means that candidates answer these items. The items are unscored, and so it doesn't count for or against them on their test. But it's helping us gather metrics to determine the quality of the item and how does it perform. Those items are piloted with a minimum of 300 candidates. If they don't have 300 candidates, they can't come off the test. But once they have 300, we can take them down and then actually examine them to see how they performed. When they are examined, the statistical analysis, we look at the item difficulty. Before we put it out there, when it's in that right review phase, we have no idea how difficult the item is. We can guess, we can make estimations, but the truth of it is until the item goes live and people actually answer it, we don't know how difficult it is. And so with the pilot phase, we are then able to gather metrics to tell us, oh, that item was super easy, or that item was super hard, or it was somewhere in between. We also look at, does the item, help us identify the candidates who know the content and don't know the content? Because items that, what we call item discrimination, we want those items to tell us, hey, those candidates who did really well were able to answer this. The candidates who didn't know the material weren't able to answer that. We can see that in the metrics. And of course, we're always looking at bias in our items to make sure that they don't impact any particular subgroup in a harmful way. Nadine, our lead psychometrician, our director of psychometrics, I asked her to put together a statement about this statistical analysis here. I'll be quiet here in just a second, but I do want to point out a couple things. The midway through this paragraph, it says the item must meet rigorous standards before it can move forward as a scored item. These standards are on item quality are based on professional standards, published standards from NCCA, which is our accrediting body, as well as organizations that create standards for educational psychological testing. And so if these items don't meet these metrics, we simply just don't use them. We take the data that we gathered, we can see why an item did or didn't perform, and then we're able to rework that item, and it would never go operational unless it passed the metrics. All right, I will move on. When we have a new practice analysis, we then take some sample items, some sample tests to an SME group. We help them determine what the cut score on an examination is. And so these SMEs are asked to look at a set of examination items, and they're asked to help us determine what is it that a minimally competent provider should know. And so they help us establish that cut score as to what's passing and what's not. This group of SMEs make a recommendation. It then goes to our board. They evaluate that recommendation, and then they approve it or deny it or make suggestions related to that that cut score that's been proposed to them. But again, I want to point out that that is SME guided. That is the community or the industry involved in that process. And then finally, and this is continuous all the time, is where we're looking at our items just to see how they're performing. And so we watch those items, each time we take down a publication, and we also watch them, to see items that aren't performing day to day. But it's an ongoing quality check, a quality improvement process to make sure the items are doing what they're supposed to do. And then at the end of that, 4 or 5 years pass, and then we start another practice analysis and go through this process all over again. And in this life cycle, these little explosions, these yellow explosions, are showing where there is external SME involvement, subject matter expert involvement, outside the staff of National Registry. So the SMEs help us develop the practice analysis. The SMEs help us write and review the items. And the SMEs also help us with the standard setting, where we set the cut scores for those candidates who are minimally competent. And then in a nutshell, examination content areas are identified and validated by SMEs, educators, and individuals who actually work in the field. And the picture here is of a panel that we just hosted in December of 23 in Hurst, Texas. And as you can see, these are people from all across the nation providing their input. And these folks help us identify those items that should move forward and should not move forward from that writing phase. All right, I'm going to shift now to part 3. And if you were here back in December, there was a lot of great questions that came up. And during that time, I was writing down those questions, and I'm here to report back to you on some of the questions that you had. So the first thing is, what's the new domains going to look like come July 1st, 2024? And I've kind of touched this already, but the 5 existing domains will be measured: airway, respiration, and ventilation, cardiology, resuscitation, medical, obstetrical, and gynecological, trauma, and EMS operations. And then the 6th domain, this is the new one, is that of clinical judgment. And that clinical judgment will include aspects of leadership and communication. So that will be the new domain that hits the examination come July 1st. The AMT examination actually is going to remain very similar to what it's been. It has been a computer-based test, a CBT, in a linear format, meaning that the items are fed one right after another. The duration for this examination will be 3 hours. It will have 135 items. 100 of those items will be operational, meaning they're scored. And 35 of those items will be those pilot items where we're trying to gather metrics and just see how they performed. And of those items, those 135 items, about 31 or 35% or a third of the examination will be operational scenarios, which actually measure the clinical judgment, leadership, and communication. Paramedic test, structured very similarly to the AMT test in the domains. Again, you see the 5 domains that have been around at National Registry for a very, very long time, with the 6th domain being the new one, the clinical judgment, which will hit the test July 1st, 2024. And it will also include those aspects of leadership and communication. The structure of this test is it is computer adaptive, meaning it adapts to the ability of the candidate. This examination now will be 3.5 hours. The candidates will see on a minimum side 110 operational items, 20 pilots. On the maximum side, they'll see up to 150 items, 20 which will be pilots. And the operational scenarios, again, will be about a third, a little bit more for the paramedic candidates. And so again, the structure here is almost the same. It's just introducing some good bit of scenarios on the examination. Again, remember this test is computer adaptive. And so those candidates will see somewhere, depending on their ability, as few as 110 or as many as 150 items. There were questions also about cost. And so the new examinations that will be taken after July 1st will be increased by $15. The EMT examination will be $159. The paramedic is going to be $175. There were questions about timelines. When were the scenarios introduced to the examinations? And so both of the scenarios were introduced at the AMT and paramedic levels in the fall of 2022. And the technology enhanced items were introduced at AMT in the winter of 23 and the paramedic in the spring of 2023. So kind of give you some time or some information about when these scenarios and these TE items were introduced. So those were the questions I had last month or in December. And so now I want to talk about the discontinuance of the psychomotor examination, because that tends to be a very interesting topic for folks. And so we'll start with psychomotor examinations have been examined with National Registry for as long as I can remember. The examinations have been used to measure, some concepts that the computer didn't necessarily do very well. But with the advancement of science and technology, we're able to get some of those things in a more uniform manner by offering it on the computer. And so this grid is very busy, I understand that, but I'll kind of point out a few things. I think I'm just going to point them out at the paramedic level. But if you look at the columns, the constructs that are being measured, that first row there is knowledge. And you'll see that in the navy blue up there is our current examination. The knowledge, which is terminology and factual information, has been measured at the computer site, the CAT, and it will continue to be measured there at the CAT with the new examination. The mental skills were evaluated at the psychomotor examination. And with the new examination, we know that we can actually measure those things with technology that with the computer in the future here. The abilities, the clinical judgment, the leadership and communication, that was being measured by the psychomotor examination. We know that we can do that with the computer with the clinical judgment scenarios. So those mental skills and those abilities are going to be measured through the scenarios with the technology enhanced items on the future examination starting July 1st. And then finally, this is the biggest question usually that I tend to come across is, well, how do you know that these folks can perform these skills? And so in the past, we were doing that with a skills examination. And the way that's going to be done in the future is through the attestation of the school having a student minimum competency or portfolio of those skills. And how is that better? Really, I'll tell you, there's really three reasons here. Instead of doing a one-day, one-event examination where everybody comes back after they've completed the course and do a day-long testing, the testing of those skills will be done over a longer duration, meaning that we'll start capturing skills competency from day one. So we'll be able to see that these candidates are able to perform skills in the lab. When they move to the hospital site or the clinical site, we'll be able to capture it there. And then finally, when they move to the ambulance, we'll continue to capture that skill development and that skill competency. So it's really from the beginning of the class to the very end of the course instead of a single day. The other perk is that these skills competencies are being measured in differing sites. So it's not just back in the classroom at the end of the course. We capture that skills competency in the lab, in the hospital, in the field setting. And also, instead of being a single evaluator, because it's in differing locations and over a longer duration, there's going to be multiple evaluators. And so all of that will be captured in a portfolio. And that's how we'll know that that person has that competency in those given skill sets. Again, if you're a school, you can continue to do skills testing if you want. There's nobody saying that you can't do that. In fact, if you feel like that's necessary, you should do that. But again, our method is now going to be this portfolio package that shows competency over a longer period with multiple evaluators and in different settings. So that's how I would answer that question that often comes up. The other rationale behind this decision is National Registry is an accredited certifying body. We are accredited by the NCCA. NCCA was formed in 1977, and their goal was to develop standards of excellence and to ensure the health, welfare, and safety of the public. And so in 1989, they expanded their roles to include all certifying bodies. But what they do is they are a third party that validates certification industry organizations like National Registry. They're a third party to validate what we do, and they are impartial, they're external, and they say, yep, you do things well, and they grant us an accreditation. Or if we don't do things well, they don't grant us an accreditation. And so really what this boils down to is the adherence of standards of educational and psychological testing. And so this is really important to our organization and to our board. And so to maintain these accreditation standards and meet these standards, we too have to make changes to maintain our accreditation. The EMS community also gave us a good bit of feedback about the psychomotor examination. There was a lot of folks. It's really interesting when you go out there and talk to people. There's probably people fit in three categories. They are all for getting rid of the psychomotor examination. There's another third that's reluctant, and then there's another third that really doesn't have an opinion on it at all. But there's some people that we couldn't retire the psychomotor examination quick enough. But the reason why we can is because there's been major advancements in the testing practices and the testing science. There's a huge call for modernization and efficiency in our examinations. And the truth of it is we're one of the final healthcare occupations that are actually doing a psychomotor examination. And so because of the science, the NCCA accreditation, the EMS industry, we're really trying to align with the science, the other healthcare occupations, and be up to date with the best known testing practices. So when is all this going to happen? The last day for the psychomotor examination is going to be June 30th of this year. And the new examinations for the AMT and paramedic will start on July 1st. So there's going to be a switch that occurs, and everybody will be in the new testing manner come July 1st of 2024. So really the question is, what does that mean? So a candidate who has passed their cognitive test and their psychomotor examination before June 30th will be certified just like they are today. But those candidates who have not passed the cognitive or the psychomotor, so they haven't completed both portions of the examination by June 30th, will go into the new process. So these candidates must take the new AMT and paramedic certification examination, whatever's appropriate to their level. And so the point here is that these folks have to get through the process, both the cognitive test and the psychomotor test before June 30th, because if they have only one or the other one done, come July 1st, they're going to have to enter the new process. So we are working hard to provide our stakeholders with support and resources. We do have a good bit of emails, social media blasts. We're putting resources on our website to help people prepare for this change. We remain committed to fair, accessible, and reliable examinations. And of course, we too have policy constraints and things that we have to adhere to maintain our accreditation and to be up to date and using the latest science when we build our examinations. We have hosted or are working with NAEMSE to host 4 different workshops that talk about how does an educator prepare their staff, their program, their students for this new concept of clinical judgment. These workshops are called Educating and Evaluating Clinical Judgment for AMT and Paramedic Educators. We have done one workshop in August of 23. It was our West workshop that was done in conjunction with the NAEMSE Symposium on August 16th of 2023. Unfortunately, I just found out today that the workshop in Hurst, Texas, this is going to be our South workshop, coming up in about a week or two, has met capacity. And so the registration closed with 100 attendees in the South workshop in Dallas-Fort Worth, Texas, and that was the South. The good news is that there will be 2 others. The next one, and this one is available for registration right now, and Rio's going to drop this in the chat, but this is our North workshop, and this one will be held May 17th. It's a Friday, and it'll be held in the Chicago area. So folks who are in that part of the country will be able to come. And then the 4th workshop will be part of the NAEMSE Symposium on August 14th of 2024 in Pittsburgh, and that will represent the eastern portion of the United States. And so again, we've had one workshop. The second one happens in about a week or two, but there are two additional ones, the one on May 17th and the 4th one, which is August 14th of 2024 in Pittsburgh. One quick reminder here before we move on. The testing process as we know it today for AMTs and paramedics will end come June 30th, 2024. And there'll be a new testing process starting July 1st of 2024. To help ensure that there are adequate number of psychomotor testing sites in June of 2024, we are contracting with some sites who we have need in different parts of the nation in specific geography. And we'll compensate these sites with a contract for actually performing psychomotor testing in June of 2024. Some of the stipulations in the contract is the site has to be open for all candidates. You must offer same-day retesting, and the candidate cost can exceed $300 per candidate. If you have an interest in this, you can reach out to Matt. He can give you more of those details. But we will contract with sites where we have need. And so again, I know right now our bigger needs is kind of in the mountain region, believe it or not. We would love to have a site in that area so that we would have for sure guaranteed psychomotor testing in that region of June of 2024. And then finally, the last topic, and I've already kind of touched this one, is the 2023 practice analysis. So the practice analysis at the BLS level, so we're talking EMR and EMT, did occur. And the impacts will probably occur sometime in 2025. And the impacts are really going to be that there's going to be new domains in these examinations. And here you see the domains listed. So scene size up and safety, primary assessment, secondary assessment, patient transport and treatment, and finally operations. These will be the new domains on the AMT, I'm lying to you, the EMT and the EMR examination. Before we go to questions, I'm going to leave this up. We have a lot going on at National Registry. I was only able to touch on about 4 to 5 things today, but I promise you there's a lot more going on. And if you go to this QR code, it will take you to our page that discusses our key initiatives and some of the things that are occurring at National Registry. It's a great way to stay up to date with what we're doing at National Registry and just kind of have a summary of what's going on. And of course, if you have other questions, please reach out and we would love to address those. So that's kind of everything that I had to present today. And we'll go back to questions.
Okay, the first question comes from Christine Loretano. Does every exam taker, regardless of their score, get exposed to pilot questions? And are the same pilot questions given to everyone, or is it randomized?
Yes, every candidate does see pilot items. Do the candidates see the same pilot items? The answer is no, because again, remember the paramedic test is computer adaptive, and so they could see differing pilot items.
Okay, the next question comes from an anonymous attendee. Since the rollout of scaled score reports, students are not getting much out of the results other than that they failed. Is it possible to bring back a little more detailed report on what category they are not passing in?
I'm going to direct that person to this QR code. In the key initiatives, there is a good bit of information about skilled scoring. And I think that would have a more comprehensive response than I could do here in the next 9 minutes. So let me direct them to this QR code and then to that key initiative that's related to skilled scoring.
Okay, the next question is also from an anonymous attendee. Will clinical judgment scenarios and multiple response TEI questions be scored for BLS, in parentheses EMR and AMT, that's not correct, EMR and EMT, excuse me, tests starting in July?
All right. Well, that's a yes and a no answer. How's that? So let me try and get both sides of this. The clinical judgment scenarios are measuring clinical judgment, which is the new domain for AMT and paramedic examinations. Clinical judgment has not been identified as one of those essential tasks for the BLS providers. So BLS, EMRs, and EMTs will not see clinical judgment scenarios on their examinations. So that's the yes and the no. So yes, AMTs and paramedics will see clinical judgment scenarios and items. EMTs and EMRs will not. Regarding the TEIs are being seen currently by AMT and paramedic candidates. They will be, not the scenarios, but the TEI items will be introduced to the BLS examinations very soon. So again, that's a yes and a no. So let me make sure I'm clear. So the TEIs currently are on our AMT and paramedic examinations. The EMRs and the EMTs are about to see them, but they're not connected to a scenario. They're a standalone item.
Okay, the next question comes from Ricky Evans. Does NREMT suggest test prep apps for students to use to get ready for the test?
We do not endorse any provider of any sort there.
Okay, the next question comes from Mark Self. Are SMEs geographically distributed? If not, why?
Yeah, they are. So the way they are geographically distributed is we use the NAEMSE, that's the National Association of State EMS Officials. They have 5 geography zones that they use across the nation. When we have a panel, we make sure that there is a SME from each of those regions. So a panel would consist, that's why the minimum is 5. The panel would have at least one person from each of those regions, because medicine can be very regional. And the purpose of having those at least 5 SMEs is to flush out any regionalness with a particular item.
An anonymous attendee asks, are questions weighted based on difficulty?
No. Again, the AMT test is a linear examination. The weighting comes during the standard setting. So they look at the examination in its totality and decide what is the cut score for that examination. At the paramedic level, a candidate, again, the test is adapted to them, and the item can move quickly with that candidate to determine, are they above that cut score or below that? And when the test has a 95% confidence interval that they are competent or not, it then shuts off. And that's why you have that variability between 110 and 150 items.
Okay, the next question comes from Gary Hall. Why is the exam for AEMT linear while the exams for EMR, EMT, and NRP are all computer adaptive?
The rationale behind that is when you build examinations, CAT examinations, the bank is huge because, again, that test is adapting to the candidate. And so the pool of items in a CAT test is really, really big. Whereas a linear CBT examination, the amount of items that are required are less. And I would tell you, up until recently, the volume on the AMT examination has been very low. It has not been a high volume examination. And so to build a bank that's huge is very costly. And so we have not gone to a CAT examination at the AMT level at this point.
The next question comes from Anthony Kepler. Is a state free to use whatever scenarios they deem desirable for use during the physical skills testing? Is there a role of oversight from the NAEMT as to the validity and reliability of state-created scenarios?
I don't really understand that question. I don't know if you're talking about scenarios when it comes to psychomotor testing or the scenarios that are going to be on these examinations.
I think it has to do with the psychomotor testing. They reference physical skills testing.
So no, those are written again, through that process where we bring in SMEs and build scenarios based on the practice analysis as to what it is that EMS providers are doing. And so again, through that scenario writing and the review process, that's how those scenarios are built. I will remind you, though, that the scenario testing will go away on June 30th of 2024. So we are in the final months of the psychomotor examination.
The next question comes from Barbara Mattison. Will AEMT be moved to a portfolio type system as the paramedic type?
Yes. So the AMT portfolio is a little bit more complicated because the paramedic programs are accredited by COA, but there is not a national requirement for AMT program accreditation. And so earlier last year in 2023, we worked with NAEMSE, the National Association of State EMS Officials, to produce a model SME document that a state could adopt. And so at this point, that was turned over to the states in probably about summertime of 2023. And the states now are creating a portfolio system for the AMT, and that will be state by state. So I would direct you to your state officials to see where they are and what their requirements are going to be for an AMT SMC document.
Okay, we only have time for a few more questions. This next one comes from Joel Demers. Please repeat what I think I heard. An AMT or paramedic candidate who has taken and passed the cognitive exam by June 30th, 2024, but not yet passed the psychomotor exam will be required to take the new cognitive exam on or after July 1st, 2024. There's a couple of different questions kind of along these same lines, Paul.
Yes. So yeah, so I went back to that slide. So here it is. Candidates, first row here, candidates who have passed the cognitive and the psychomotor prior to June 30th, they passed, they're certified, period. That one's easy. Number two here, candidates who have passed the cognitive examination before June 30th, but not completed the psychomotor examination, will have to enter the new process on July 1st. The opposite is true. Candidates who have passed the psychomotor examination prior to June 30th, but have not passed the cognitive, will then have to enter the new process on July 1st. So yes, I think if I heard the question correctly, that is correct. They have to complete both the psychomotor and the cognitive by June 30th, or they have to enter the new process come July 1st.
Okay, we have time for one more question. It comes from Jeremy Ricks. On the scaled score reporting document online, it mentions that things are not changed in the method of scoring, but the grading system has. If someone performs subpar in one area, based on that reading, will they still fail even if they are exceptional in all others? Does this mean they will still fail just because of one area and us educators are just not able to figure out what their weaknesses are?
Yeah, our tests have never been scored in the subscales or those domains. The tests have always been scored based on the overall performance. So it is entirely possible that somebody could do poorly in one subscale and do very well in another and actually pass the examination, because the examination is based on its totality, the scoring. Again, it's not scored by ARV, cardio, med-OB-GYN, trauma, or ops. It is a score over the whole performance of that examination and not the subscales.
Okay, thank you, Paul. So we are at the end of our time here. I dropped an email into the chat. So if we were unable to answer your questions live today, please reach out to support@nremt.org. Also, check out our key initiatives link that Paul has up right here. Thank you all for coming. We want to thank the National Association of EMS Educators for hosting us today. We very much appreciate that partnership. Rio, Paul, any last words for folks?
No, thank you for attending. We're glad to have you.
Yes, thank you, Paul and Emily, so much for being here. We also super appreciate our relationship with the NREMT. Everyone, I did put a link in the chat to obtain your CE from this webinar, but tomorrow you will receive a follow-up email with all of the information that you need and a link to the presentation and the recording. So with that, I hope everybody has a fantastic rest of your day, and we will see you next time. Thank you.